Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, die Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Professor Børge Nordestgaard in Copenhagen, Denmark, in order to discuss the impact of remnant cholesterol in patients with chronic kidney disease and maybe also more generally in cardiovascular disease. Dear Borge, we are honored to host you again. Thanks for joining us.
Thank you so much.
Yeah, dear friends and dear colleagues, we're very honored to have Børge Nordestgaard with us today. He's clinical professor at the University of Copenhagen, and he's the founder and the brain, I think, of the Copenhagen General Population Study. And actually, we have to congratulate at this point because Borge will start his presidency of the European Atherosclerosis Society this year. And so, again, we're honored to have the president of the EAS with us today. That's great. And I have to focus and highlight another fact, because Borge is one of the few guests that have been at Marcus at Home more than twice. And I counted the visits, and today, I think, if I correct me, if I'm wrong, today is the third visit at Marcus at Home, and that's great, I think. And I think this fact reflects the standing and the impact of the research, and of course the interest of the whole team of Marcus at Home. And as Gunnar said, the topic today will be remnant cholesterol and the CKD, and your latest publication in ADVB in late 2024. And now I stop and finish. And so, Borge, the stage is yours.
Yeah, thank you so much for this very kind introduction. It's actually me that's very honored to give this talk. So I'm very happy that you're interested in this topic, remnant cholesterol, and particularly in chronic kidney disease. I will start with a brief talk about what was the latest paper about, and then we can broaden the discussion out to talk about anything about remnant cholesterol you would like, because it's relevant not only in chronic kidney disease, but in many different people. So the overall topic is remnant cholesterol impaired kidney function. And you can see my various conflict of interest down below. And there's certainly president of EAS is one, but also the Danish taxpayer. They pay all my research, my wages, and so forth. So this is the paper we talked about. The first author is Daniel Elias Lopez, who came as a postdoc from Mexico and worked with me for 2 years, and some of my other colleagues in Copenhagen. So the title is Impaired Renal Function with Higher Remnant Cholesterol Related to Risk of Atherosclerotic Cardiovascular Disease, a cohort study. And here's sort of like the bottom line, or central illustration, if you will. So it's based on the Copenhagen General Population Study, where we have 10,000 individuals with impaired renal function. And when we look at the hazard ratio for atherosclerotic cardiovascular disease for 1 millimole per liter or 39 milligram per deciliter higher levels, then when we look at everybody, you can see that remnant cholesterol here has a much higher hazard ratio than LDL cholesterol. And this is particularly true here in the statin users. So remnant cholesterol increases risk, but in fact, LDL does not when you're already on a statin, probably because statin took away a lot of the LDL. And then when you look at the statin non-users, both LDL and remnants for the same increase in cholesterol content are important, but again, remnants are more important than that. The second half of this part is that we estimated the excess risk of atherosclerotic cardiovascular disease that is explained by elevated remnant cholesterol. You can express it as a percent of all. And when we look in statin users, 1/4 or 25% of all the ASCVD in chronic kidney disease was explained by remnant cholesterol. In non-users, it was 8%, but here you can see also LDL cholesterol was also important. This is the design of the study. So we started with 108,000 individuals from the Copenhagen General Population Study. And here I show you some cross-sectional data on lipid levels. And then we selected the 10,000 that had impaired renal function, defined as baseline eGFR less than 60 milliliter per minute per 1.73 square meter. And here we look at prospective analysis with 9 years of follow-up. At myocardial infarction, about 600, ischemic stroke, about 600, and about 1,200 combined ASCVD events or atherosclerotic cardiovascular disease. Here's what you see is in these 108,000 individuals, as eGFR goes down, what is the concentration of different lipid fractions? And you can see total cholesterol goes up, but when we get here to a T4 level in impaired kidney function between 30 and 15, cholesterol drops, LDL drops, and HDL drops. But there's one lipid fraction that does not drop, but actually goes up. It's remnant cholesterol. When you look at these other values, again, you can see total ApoB goes down, non-HDL cholesterol goes down, but triglyceride goes up, corresponding to the remnant cholesterol going up, as I showed you before. Here's just with focus on LDL and remnants. LDL, of course, because that's the one that we have been focusing most on in clinical practice. So this is all individuals, and you can see the numbers below down here with lower and lower remnant or eGFR. But you can see, if you look at the orange bars here, that remnant cholesterol goes up whenever eGFR goes down. And this is true also for statin users. You can see the orange bars are larger, but it is also true for non-statin users. You could be overwhelmed, you would say, by all the LDL. And that's what many people also think about. They think, well, there's actually more cholesterol in LDL than there's in remnant cholesterol. But there's now a lot of evidence that the cholesterol in remnants is more important for atherosclerotic cardiovascular disease than the corresponding value of LDL cholesterol. This is tried to show here. So this is atherosclerotic cardiovascular disease in the individuals with impaired renal function from our study. What you can see, so it's a total of about 9,000 individuals here. When you look at it, then this is for a hazard ratio for 1 millimole per liter of 39 milligram per deciliter higher remnant cholesterol or LDL cholesterol. And then we also here show for higher ApoB, because these days there's a lot of focus on ApoB, but ApoB is basically a measure of both remnants and LDL. So in all individuals, the risk goes up a lot for remnant cholesterol. These are in the people with impaired renal function. LDL is not very important. And ApoB is sort of like a bit in between these two, as it is a composite of the two. When we focus on the statin users, here it's clearly the remnant cholesterol that is the residual risk, you could say. LDL is not anymore, and ApoB in between. In those without statins or lipid-lowering therapy, both lipid fractions are important. Also, you can see the ApoB value. And then the next we did was to calculate, I'll try to explain it slowly, the excess risk of ASCVD that is explained by elevated remnant and LDL cholesterol. So what you do is that you look at the 10,000 individuals with impaired renal function, and you compare them with the 98,000 without, to look at what is the risk of ASCVD, composite of heart and brain atherosclerotic cardiovascular disease. And then you calculate the 100%. And then later, you look at how much of that can be explained by elevated remnant cholesterol, how much can be explained by elevated LDL cholesterol. That's what's called a mediation analysis. And here's all like the first leg. It's what's the total risk, not taking LDL and remnant into account. So when you look at all the individuals, this is the risk for myocardial infarction, ischemic stroke, and the composite. And here the risk increases for those with versus without impaired renal function. So you certainly can see it's not a good idea to have impaired renal function. We know that already. We know that for years. That's what they die from. Eventually, that's ASCVD. And if you look at the statin users, values are here, and non-statin users. So next we calculate this fraction with mediation analysis. How much of this 100% risk is explained by elevated remnant cholesterol? How much is explained by elevated LDL cholesterol. And this is shown here for all individuals. So if we focus on myocardial infarction, you can see remnant cholesterol explains about 6%, LDL very little. For ischemic stroke, remnant cholesterol even more, LDL some also. But the two added together, ASCVD is explained 10% by remnant cholesterol and 6% by LDL cholesterol. But remember, this is statin users and non-statin users combined. So this is what I showed you before. But when you now focus on statin users, only remnant cholesterol explain part of the risk. And we look at all the endpoints together, ASCVD, then it is 25% that is explained by high remnant cholesterol. And there's no red parts here. LDL does not explain. When you look at non-statin users, both remnant cholesterol and LDL cholesterol explain risk. LDL actually a little bit more than remnants, but that's why all patients with impaired renal function should have statins. So I'll end with the same slide that I started with, namely the bottom line that using the Copenhagen General Population Study with 10,000 individuals with impaired renal function, when we look at a 1 millimole or 39 milligram per deciliter higher levels, what is the hazard ratio for atherosclerotic cardiovascular disease? And when we look at the statin users, remnant cholesterol is really important, LDL is not. Non-users, they're both important, but for the same increase in cholesterol content, remnant is more important. And when we do calculate the excess risk of ASCVD explained by elevated remnant cholesterol, in statin users, remnants explain 25%, in non-users, 8%. So that was my introduction. So we can come over to any questions from now on.
Well, thank you so much, Borge, for this, again, excellent insight and superb talk and trying to get this not so easy matter across to our listeners and to ourselves. To be very honest, I'm not sure whether I understand everything correctly. So let me, if I may, begin to ask some questions. You talked a lot about relative risk, and I think I got that. What about the absolute risk? So is it what we see? I know this is observational data, obviously, but is it a shift from an LDL dependent risk to a remnant cholesterol dependent risk? And or is what about the total risk? I mean, if we have patients on a statin, CKD patients on a statin, we lower their risk, we know that, but would that be attenuated by the remnant cholesterol, or is that on an absolute basis much lower? I'm not sure whether I got that correctly.
No, I mean, on an absolute basis, these estimated excess risk, they will account both when you look at it as a relative risk or if you look at it as an absolute risk. So the excess risk, it's just you use the hazard ratios first from chronic kidney disease to ASCVD, and then you take into account how much of that explained by LDL and by remnants, and both of them will be, whether it's relative or absolute risk, the excess risk will account for the same. So remnant cholesterol will explain in statin users with impaired kidney renal function, remnant cholesterol will explain 1/4 of all the ASCVD strokes and myocardial infarctions.
And how in clinical practice now, how would we advance that or approach that issue at all? Because you showed nicely that remnant cholesterol is not the same as non-HDL cholesterol.
No.
So it's a lot of it is triglycerides. I guess if I got that correctly.
Yeah. So it's so remnant cholesterol is, so it's like if you try to very simple, then what are the bad cholesterol in plasma? And of course it's LDL cholesterol because there's most LDL cholesterol. But in some situations when triglycerides go up, a lot of the cholesterol will be in the remnants. And then I focus on the remnant cholesterol. I know many of us that see patients clinically, we tend to look at the triglyceride value because that's what comes in the lab report. That's why actually here in Copenhagen, automatically, if you order a triglyceride, we will also calculate the remnant cholesterol. We also calculate the non-HDL cholesterol. And as what you said before, non-HDL cholesterol is a composite of LDL cholesterol and remnant cholesterol. And So you could look at, so you say if you have remnant cholesterol is high and you have actually brought down LDL cholesterol by statins or other lipid-lowering therapy, then the difference between the two is remnant cholesterol. But I think it'll be a little while before everybody understands it. And that's why here in Copenhagen, we simply just give that value also so you can look at it.
Well, the interesting and still a little puzzling part of that is that we saw so many studies trying to interfere with triglycerides that all up to now, permethylbrate was the last one, didn't have an effect on cardiovascular events. So would that be in contrast to your observation?
No, I don't think not at all. I mean, so all the first triglyceride-lowering trials, the fibrates, when they were done in people without statins, there was a very nice effect, and actually particularly the ones that have high triglycerides, and that means they would also have high remnant cholesterol in the beginning. So it's all like, it's very strange because the fibrate trials, most of them were originally LDL trials. They just recruited people with high LDL cholesterol, and then they gave them fibrates, just like you did with statins. And then you can't afterwards argue that because they were not positive always, then it doesn't help to reduce triglycerides because they were not designed to reduce triglycerides. So the only one that was actually really with a fibrate was this PEMA fibrate, the prominent trial, which I was part of running myself also together with Paul Ritger and others. And there, remnant cholesterol was reduced, but at the same time, unfortunately, LDL went up. So when you look at ApoB also went up. So that means the totality of atherogenic cholesterol or particles in plasma went up in the prominent trial. So there's no wonder that there was no positive effect. And of course, this is also difficult for people to understand. So what we do need is, I mean, for the future, some much more potent remnant cholesterol and triglyceride-lowering drugs, and they are on the way. Maybe you plan to talk about them later, ApoC3 inhibitors, anti-PTL3 inhibitors, and maybe even anti-PTL4 inhibitors.
I don't want to, Gunnar, I don't know about the nephrology part. I don't want to ask too much there. I was, if I got that correctly, a little surprised how few in that observation of the CKD patients were on statin. Was that correct, that the majority was actually not on statin?
Yeah, I think so. Yeah, sure. I mean, but that's
probably the same in Germany. But that's
I'm sure the German doctors are much better than the Danish. But
no, they're much worse, I think.
No,
but I think this has been surprise to me also that when I talk even with nephrologists in Denmark, they say they don't get lipid lowering to all the patients, and I simply don't understand it because they die from atherosclerotic cardiovascular disease, and one of the best proven drugs against that, of course, hypertension drugs are very good also, but that is lipid-lowering drugs. It was the same for me. I can tell you, when I started on talking about cholesterol and statins, when I talked with the diabetologists in Denmark, and you should think they were very advanced. We have Novo Nordisk and things, but it took many years before the diabetologists in Denmark started giving statins to their patients. Now they give to all of them.
And you picked your patients or participants actually from general population. So I guess many of these people who were invited to participate were not aware that they had CKD. And same would be here. I guess we have millions of people who have, say, GFR between 45 and 60 and are not aware of their CKD, and therefore nobody would have started statins. So if I got it right, people in Copenhagen were invited by mail. I guess it's some years ago, so it was not email, but conventional mail at that time. And you just picked a representative part of the total population of Copenhagen. Is that correct?
Yeah, we just take one part of Copenhagen at a time, and then we invite everybody. I have done a lot of genetic studies, so I chose to only have the ones of Danish white descent. But that's simply because the 10% of people of not Danish descent are from all parts of the world. Some is from America, some from Germany, some from Pakistan, some from Turkey. So genetically, the 10% of the Danish population not being of Danish descent is very difficult to study. But it is correct. This is simply a representative sample of the Danish general population. 43% of those who invited turned up. I myself was just one of them. I live in the area, right? So I get the letter also.
Well, I think a very useful hint for clinical practice is to actually have the laboratory report these parameters, which is absolutely easy, as you alluded to. It's just a matter of calculation. And what we do here is have non-HDL being portrayed in the laboratory sheet, but then calculating remnants would just as well be possible. I mean, it's easy to do oneself, but it's obviously nicer if you have it on the sheet of paper, also in your discussion with the patient.
Yeah, I fully agree, because then that actually makes the single doctor be aware when they suddenly see that remnant cholesterol is high, and it's not only non-HDL. Because why I don't like non-HDL so much is because most doctors, when they see patients, they will think non-HDL cholesterol is just a little bit different from LDL, so just an advanced LDL. They don't really understand what is the difference between non-HDL cholesterol and LDL, and that's why we show all three of them: LDL, remnant cholesterol, and non-HDL cholesterol.
Do you know, I don't know, have you looked at that, diabetes and CKD? Has that something to do, or can you say that impact of diabetes and from your population? Because I was thinking of triglycerides is a major problem in diabetes as well.
Sure. I don't think we don't have enough power. It sounds crazy, but we start with 110,000, and then when you first take 10,000 with chronic kidney disease, and then you have to take the ones with diabetes within that, we might be able to do it. But actually, I talked about we should do more studies and maybe do both the Copenhagen studies together with the UK Biobank, and then I think we will have power enough to look at it. But we haven't looked at it specifically yet.
Do we need, so coming back to the lab values, do we need to measure EPO-B regularly? Because many people recommend us to do so. It's very expensive. Admittedly, I hardly ever did it so far. Would you see patients in whom it would really give additional benefit?
Yeah, I mean, it's very parallel to non-HDL cholesterol. So I think for the majority of people, you're fine with just looking at the non-HDL cholesterol and then also the remnant cholesterol. And there is some patients, of course, where they have high ApoB. So when you look at all the epidemiology, ApoB is actually a very good marker of risk, like non-HDL. We worked on also comparing these two, but that's all like in our big studies. And then the latest we have done now, not published yet, is that we can see that for the majority of patients, whether you use ApoB or non-HDL cholesterol, it gives roughly the same risk estimate. However, when you do what's called a discordance analysis, when we see the ones that have high ApoB, but not very high non-HDL cholesterol, then there's additional risk. But the other way around is also true. So if you have some with high non-HDL cholesterol without very high ApoB, they also have excess risk. So both of them have some information. But for the average patient, please just look at non-HDL cholesterol and, as I would say, remnant cholesterol also. You should just talk with your local clinical chemistry laboratory and ask them to give the value. It's just non-HDL cholesterol minus LDL, that's all. It doesn't cost anything. It's just one more line in the lab report. That's all it is.
You mentioned discordance analysis. This I've never heard about that topic. And statistical prime or statistical question. Could you just refer to our viewers in a nutshell what that is?
I don't want to complicate things too much. My trade was actually simplification, but now that you ask about it, what you do is you do a maybe 2 by 2. If you look, for example, of you could do LDL cholesterol versus remnant cholesterol. Then you look at the reference is the one that both have relatively low LDL and remnants. Typically, you take the median value. And then you, in one corner, it's like the four of us here, right? So down where Stephan is, that's where they're both low, and where Gunnar is, that's where they're both high. And then where you are, you would have only high LDL cholesterol, and where I am, you will have only high remnant cholesterol. And then you just look at the references, Stephan, and you look at the three other ones. What is the hazard ratios? And then you see that if you only have high remnant cholesterol, you have high risk. If you only have high LDL, you have high risk. And if you have both of them, you have the highest risk. That's a so-called discordance analysis.
It sounds complicated, but in the end, it's fairly easy, as you said.
I mean, in clinical practice, you'll have a patient ahead of you, and then you'll see that the patient, the lipid profile is dominated by high LDL, like F8, and then you focus on that. But you have another patient, for example, impaired kidney function, or it could be some other reason also that have mainly high remnant cholesterol, and then you should focus on that because either one of them confer very high risk of atherosclerotic cardiovascular disease. So statistically, it might sound complicated to you, but in clinical practice, it's not more different than what a clinician look at a lipid profile. It's the same.
Most of the time, we observe a large gap between LDL cholesterol and non-HDL in patients with high triglycerides, in diabetics, as we alluded to. So one wonders obviously about possibilities to therapeutically interfere. From your study, do you have any data on lifestyle factors at all, such as BMI, obesity? Is there a correlation with you? Do you have any kind of longitudinal data where you could, because we sometimes observe that, right, in people who actually do manage to lose a lot of weight? Talking about the novel drugs, you alluded to a company that provides a drug to lose weight and as an anti-diabetic, and that probably makes a large difference, doesn't it? Do you have any data on that from your study?
Oh yeah, there's. I mean, so when I look at it in our big population and look at what is the best explanation for high remnant cholesterol and high triglycerides, then it is higher body mass index. So it's really simple. People eat too much, exercise too little, they take on weight, and then they not only had fat in fat tissue, but also in the blood, remnant cholesterol. And then they also get in the liver, right? When you look at the studies now that use GLP-1 inhibitors to lose weight, then they do bring down remnant cholesterol somewhat, but it's not like it all goes away. Of course, in the ideal world where we all eat less, exercise more, have a GLP-1 inhibitors, and people will be lean like they used to be when I was a boy. There was no fat people around. I didn't see them. Or it's the same when you go to some countries these days, like in Africa. I've just been traveling in some not very rich countries in Africa. Lesotho, for example, they're very poor. I've also been to Malawi, among the poorest countries in the world. There's no fat people at all. And of course, they don't have very much of the remnant cholesterol problem or triglycerides.
And when it comes to medications, so without the novel drugs that may or may not come into clinics in a couple of years, so if I now have a CKD patient with a, say, LDL cholesterol of 70, but a non-HDL cholesterol of, say, 120, which would give a remnant cholesterol of 50, if I got it right. And if this patient is on a moderate dosage of statins, so can we recommend first to increase the statin dosage, or should we go for ezetimibe or bempedoic acid, or what would be the next step for the treatments that are currently available?
Yeah, the max dose of statin, of course, if there's no reason why the patients cannot take it. But all the evidence base is for that, and also the European dyslipidemia guidelines, they also say that they give a much, much higher grading for using high-intensive statin when you have high remnant cholesterol and high triglycerides, which I'm 100% behind. And then what they say also in these European, it's from combination of European Atherosclerosis Society and European Society of Cardiology, that you can add bezafibrate or fenofibrate in some cases, and then there's also icosapent ethyl, which of course is debated a lot because it's only a one-study trial, and there was the thing about it was not a placebo comparison, it was a mineral oil comparison. But I still read the literature from the fibrate trials that this is worthwhile, but always first high-intensity statin.
And how comes that people with advanced CKD have a decrease actually in cholesterol, even if they are not on statin treatment? So you showed us these great graphics, which clearly showed that once GFR falls below, say, 45 or something, then triglycerides go up, cholesterol goes down, even in those people who are not on statins. Do we have a good explanation for this decrease in cholesterol?
I'd say for sure, but I mean, I think the simplest explanation that some of these patients are quite sick, right? So they're devastated, and therefore you see the same with any chronic disease, like if it's chronic liver failure or heart failure or something, dementia. People eat less and they lose weight, and then because of that, and then why then does the Remnant go up as the only one? I can't say that for sure, but some of the smaller lipoproteins like HDL, for example, together with albumin, if the kidney problem is too great, some of that is lost even in the urine, right? We know that first from albuminuria, and then later HDL also goes out. So maybe that's part of the explanation. And then, the remnants are so large that they probably will not be lost in the kidneys.
But Gunnar, also to you, the question is, we know about the high cardiovascular risk in CKD patients, and then that we can lower that by lowering cholesterol. What about is there a causal relationship between CKD and dyslipidemia? I mean, is it inflammation also that has or is it's all epidemiological, isn't it?
Yeah, we have actually done it because I've spent a lot of time doing these genetic studies, and then I apologize that becomes complicated also, but genetics are fantastic because they are unconfounded. They're just the genes we get from our parents. So it's a bit like running a randomized trial. And there's one lipoprotein, which is not what we talk about that today. We have a paper that just came out in JACC last year that lipoprotein a seemed to be a direct cause of chronic kidney disease. Not the other way around, that people thought for years that if you have chronic kidney disease, you will have high Lp(a). Whether that's the same for remnants, I'm not aware of any data to show that, but that's certainly another topic that I'm working on in our group that we should try to go after.
Before maybe looking to the novel treatments, I would just like to come back shortly to ezetimibe once again. Do we have good data in how far ezetimibe and again maybe also bempedoic acid will affect this remnant cholesterol? So we generally say, well, they reduce LDL cholesterol by about 15 or 20%, and at least in my opinion, there are no real good data on this remnant cholesterol.
No, that's right. I mean, there is for statins. You can certainly calculate it, and you can see the statin trials. They reduce remnant cholesterol and a fair amount. But again, most of the statin trials did not recruit patients with high remnant cholesterol, high triglycerides. But the statins do. And I think generally, you can also look at it, if you look at how much they reduce triglycerides. So statins are a bit better at reducing triglycerides than bempedoic acid or ezetimibe, right? So, I mean, it's fine with me. I mean, if you have great risk of atherosclerotic cardiovascular disease, you should bring lipids down as much as possible. So it is perfectly fine to add ezetimibe or bempedoic acid also. But I would do first high-intensive statin and think about fibers if you're not afraid of interaction. There's this interaction, particular, of course, if you get into patients that get cyclosporine, then it's too problematic if they have a kidney transplantation. Then you should not do the combination.
Gunnar alluded to it already. What's your thoughts on the CETP inhibitors, where we saw several drugs failing in the last decades, really almost that increased HDL and didn't have an effect on cardiovascular events. Now we have novel drugs under investigation. We're first phase 2, phase 3 trials that show that they might lower LDL, and by lowering LDL actually have beneficial effects. What about remnants?
Yeah, they will reduce it a little bit also, but it's more LDL and non-HDL cholesterol. I would love to see that study was positive, but if you ask if I would take all my money and sell my house and put it into that trial, I probably would not.
And would you rather go, because you alluded to that in your talk, would you rather go if you sold your house, would you rather put it on the ApoC inhibitors? We have some siRNA drugs there in testing as well.
Yeah, ApoC3 inhibitors, definitely. Yeah, sure. Because they are much more potent in bringing down remnant cholesterol. And that's a completely different way. Whereas you could say that the CETP inhibitor that is being tested now is generally going for reducing LDL cholesterol. But for me, I might be wrong. It seems like there's so many other alternative drugs that we can use there now. Statins are fantastic. Ezetimibe, bempedoic acid, and of course all the PCSK9 inhibitors that are much, much more efficient. But I mean, if you develop new drugs and if you can get 1% of the world market for lowering LDL, I'm sure you can make a lot of money, because it is the disease that kills most people in the entire world, even in Africa.
Well, we're not an economic forum here. It's more about helping our patients. So, but that's highly interesting. Of course, if we found we always talk about residual risk, and residual risk is well described as inflammatory risk. We have recently seen some neutral data on colchicine, which was a little disappointing. And if you now very nicely show that there is residual LDL independent risk, especially in the lipids with remnants, and if we had a therapeutic target there, that would be excellent. Of course, is it? Again, as you said, a lot of it is at least correlated with body mass index. Do we need medication, or is it actually that we really have to look at lifestyle, or are we given up hope in lifestyle interventions?
No, but that's the same. But the same you could say with high LDL cholesterol. I mean, when I started talking about statins and cholesterol in Denmark, it's very simple. You could just have people stop eating all the animal products that we did in Denmark, but it went the other way. People ate more, right? So so even though we theoretically can say that lifestyle could solve the whole thing, it's not going to happen, right? Because the majority of people, they eat too much, and first so much animal fat, they got high LDL, and now the problem is that they just take on too much weight and therefore actually have high remnant cholesterol and high triglycerides. So in the ideal world, sure, you can do lifestyle, and I'm the first. That's the most sensible to do. But I'm sure all of you will be aware that when you see your patients and you say it to them, but they're basically not going to do it. I mean, it's yeah, we know. So of course you could do a lifestyle. That's fine but it's not going to work.
But maybe again, things may change with the advent of semaglutide, because my opinion is that now we have really an agent which helps the people to lose weight. Then at least some of our patients start to exercise more. And this may be the kickoff, really, which might change medicine also in this field dramatically in the upcoming years, I guess. I would have one completely different question. Børge. You did, among your thousands of publications, one that was a little bit outside the field, but also very important to our patients, where you analyzed the intake of statins depending on the reports in Danish national journals and television. A couple of years ago, I guess, published in the European Heart Journal, and where you clearly showed that once television or your main journals report beneficial effects of statins, then people are more likely to take their statins, and the other way around, once there are some discussions about adverse events, then people stop taking their statins. Now, this was in the old era with television and with journals, and now we have the social media, and we have all this discussion that news spread much faster and much more aggressive. Are you aware if anybody has ever analyzed in how far social media affect statin intake and the awareness of the benefits of statins, which we all believe in, or the anxiety with regard to side effects, which in our view are really minor and very seldom effects?
Yeah, no, I have not seen any paper where they looked at social media. Of course, that would be even more complicated to analyze than the ones we did. So I did together with one guy. He read all the news media in television, in radio, and newspapers and weekly magazines in Denmark for, I think, 15, 20 years. So that was well done. I mean, that was a big thing, but social media will be really difficult. Maybe you can do it, I don't know, I don't know if there's some way if you get all the data, you can do the IA or sort it out or something, but I have never seen a publication on it. But thanks for asking. I do agree. I mean, that it's such a shame, you could say, that we have all this fantastic evidence-based medicine that using statins to lower LDL and also remnant cholesterol really works. People have less heart attacks, they have less stroke, and they actually live longer. And despite that, there's all this fake news about that cholesterol is maybe not bad for you and statins have so many side effects, when in reality they do not have. Okay, can I be allowed to tell a little anecdote, because I think it's interesting. I was invited to give a talk in Kyrgyzstan, which is a former Soviet Union republic up in the mountains next to China. And then one day, two cardiologists took me on a day trip up in the mountains to show me some beautiful landscape. And then it was a long drive. And then there was a young guy speaking English in the back together with me. And in the front, there was an older doctor, and he didn't speak any English, like almost everybody in Kyrgyzstan. And so after driving for a couple of hours, this young doctor said, "Do you really believe in this statin intolerance? Because I've never seen one." And he was a fully trained cardiologist for several years. And they said, "No, that's exactly right. People get it in their mind because of news and social media and Google." And then I said, "Let's test." We asked the old cardiologist driving the car. And then I said, can you translate, how many has he ever seen with statin intolerance? And then he was sitting in the front, and he was sitting with his finger, 1, 2, 3, 4. He had met 5. And then I said, roughly how many patients in cardiology have he experienced? And then he said, about 5,000. So that was 1 in 1,000. That's exactly the number you get in the randomized trials. And there was no English in Kyrgyzstan, just Russian and Kyrgyz.
How do you plan to expand, or even do you plan to expand knowledge on remnants? Because I find it so interesting. You mentioned numbers and patient numbers. You need a lot. Can you do Mendelian randomization trials, or does that already exist?
Oh yeah, it does exist. Yeah, we've done quite a few of those, but from writing a few papers, it takes a long time. So I keep writing papers on remnant cholesterol, also with genetics and Mendelian randomization. I give talks, and now for the last couple of years, I try to do these searches in Scopus, and you can see now the number of publications mentioning remnant cholesterol just goes up like that, goes way up. So now in Europe, in America, in China, there's lots of researchers that start focusing on that, and then eventually that will come through and more people will talk about it. So it'll be a while. And then there is these new drugs. There was a couple of publications in New England Journal of Medicine from Arrowhead. It's a company. They have an ApoC3 inhibitors and an NGFP3 inhibitor. And there they reported also reduction in remnant cholesterol. In one of the drugs, 50%, and the other one actually 80%. So with these new drugs, and there is being planned phase 3 trials focusing on reduction in remnant cholesterol. I'm sure you know yourself that if they are ongoing, then more people will be interested. That's exactly what we've seen now with the Lp(a) field, that because there's 3 phase 3 endpoint trials ongoing, then suddenly there's a lot of clinicians that are becoming interested in it because they hear about it at the big meetings.
Yeah, I have to add one final question from my part. So do we need both classes of drugs or both targets, or would ApoC3 be sufficient, and is there no additional benefit of targeting NGLPT3?
Yeah, Gunnar, I've had that question so many times, and I've been in research so many years, so I say that only very well designed and large phase 3 trials can tell you whether one is enough or you need both or they do something different. So we have to wait and see if somebody will fund these phase 3 trials and what they will show.
So I think at this point, that might be a good conclusion, and we have to say thank you again, Borge, to being with us tonight. We learned a whole lot of interesting facts, and we learned that we should focus on remnants, and even we should start to measure it, and not only in CKDs, but we learned that it really makes a difference in risk in people with CKD. And thank you for that new insights, and thanks again for being with us tonight.
Yeah, I thank you for inviting me. It was a great honor and very interesting to discuss with the 3 of you.